So, a very good evening to everyone, and welcome to this webinar on common errors in aerosol therapy in children. I'm Dr. Ankit Parakh. I work as a consultant in pediatric pulmonology, allergy, and sleep medicine at BLK Hospital and at Children's Chest Clinic, New Delhi. So, we all know that inhalational therapy is the key for treating any child who has asthma. But we all know that there are a lot of errors which happen in this inhalational therapy, and that is the backbone of treatment. So we will talk about a few common errors which anyone can make whenever we are prescribing aerosol therapy in children or inhalational therapy in children, and how do we rectify those errors. So let's start with a case. So this is a 9 years old girl who was referred to us for non-improvement of her asthma symptoms. Now, once we look at her details, she's a 9 years old. She was well till 3 years of age. She started having episodes of cough, which usually went to the chest. And these episodes, or asthma-like episodes, were initially 3 or 4 times in a year. She used to improve with nebulizations which were prescribed and some oral medicines. But since 2018, the number of episodes increased. She was having 6 or 8 episodes a year, and she was started on inhaled medicine, and that was the right decision to put her on controllers. Budesonide 400 microgram total dose was started. But the problem was that she wasn't improving, and since January 2019, she got 3 or 4 episodes, and we saw her somewhere in March or April in 2019. On examination, when we examined her, she was otherwise a well child, was having a bilateral wheeze. Now, there are a lot of questions which anyone would like to ask, but the focus of today's webinar is on inhaled therapy. And let's talk about what's going along with the inhalers which she was prescribed. So we all do understand that yes, Rimgem was prescribed the right drug, the right dose, and she was on preventive therapy, but why wasn't she improving? So let's look at the inhalational part which we are focusing today. So when were inhalers started? Who gives the inhalers? The child takes it herself, the parents give it, do they supervise? How often the doses are missed? And you can also check that in how many days she actually needs to replace her inhaler. So for example, if you have a inhaler which contains 200 doses and you give one dose twice a day or one puff twice a day, then it should work for something like 100 days. But if you need to refill the inhaler every 150 days, then obviously she is missing doses. Is she actually using a spacer? How does she take her inhaler? So have you actually checked the way she takes her inhaled therapy? And we also asked the mother and the child that, do you know the benefits of inhalational therapy? So the answers were, Doctor, she was started on inhalers last year after the PICU admission. Well, that was the correct thing. So usually it was supervised by the mother, but now, she's well trained, she's an old child, and, she can take it on her own. The mother wasn't really sure how many doses are missed. And the mother also says, and this is the usual story, doctor, she's a grown-up child, can't she take it without a spacer? She can take her inhaler directly. Do you know the benefits of inhalational therapy? Well, we were asked to use inhaler, doctor. We were told they are quite good. But doctor, you also know that, they can be addictive. They have steroids, Doctor, it had to be taken at least for a year. And doctor, does it cure the disease? So as you see, there are a lot of things which we have thought they're going right, but they're actually not going right. And which includes a lot of apprehension in the mind of the parents and the caregivers about inhalational therapy. So whenever you are starting inhalational therapy, there are a few basic things which needs to be done. And the first step is we have to explain the advantages of an inhaled therapy. We have to dispel the myths and fears. We have to select an appropriate device and we demonstrate how to use the selected device. So let's talk about the advantages of inhaled therapy. And I know that everyone knows the advantages of inhaled therapy. So what we are trying to focus is that we should communicate these advantages to parents to improve adherence to what we tell them. So we should tell them the difference between inhaled and oral. We have to tell them that inhaled works directly, the doses are very small, the onset of action is rapid, and the adverse effects are mild or none. So the smaller dose, the targeted delivery, the quick action, and less side effects. So these points should be emphasized to parents whenever we are starting inhalational therapy. So I would say the first error is actually not prescribing inhalational therapy, and we see a lot of patients who have asthma, who have persistent asthma, and they are on oral therapy and they are on nebulization. So I think inhalational therapy is a big yes for a child with asthma, and everyone should go for it. The second would be to dispel the myths and fears, and we all know, you're all senior pediatricians, and everyone knows that there are lots of myths and fears which accompany inhalational therapy, and we should dispel all them. So usual questions would be that is the inhaler therapy very strong? We have to emphasize the microgram of the drug which you are giving in an inhaler device. So budesonide inhaler 200 microgram, not milligram. Is it addictive? Well, obviously no. It has no drugs which cause dependence. Is it expensive? Well, obviously no. Initially, they might find that you have to buy an inhaler and a spacer, and it costs something like somewhere between 600 and 1000 rupees. But ultimately, it's going to be cheap because spacer would last for months, and inhaler obviously would last for 2 or 3 months depending on how many doses it has. And is it easy for children to use? Well, obviously yes, but how it is to be used is our job to tell them, teach them. And we have to emphasize that it is the first choice and not obviously the last resort for any child with asthma or wheezing. So asthma education is the key. We should provide the parents and patients with skills which are necessary to control asthma and to improve outcomes. It requires a lot of repetition and reinforcement. It should begin at the time of diagnosis, and we should continue in follow-up. And we should not forget that during follow-up, it should be repeated, and every time it should be repeated because parents tend to forget it. We should provide a well-written asthma action plan that should include daily management and how to recognize and handle worsening asthma episodes. This is quite important, and we'll show you an asthma action plan as we go along in the talk. The components of education should include basic facts about asthma. How do you define a well-controlled asthma? Because a lot of parents don't understand what control of asthma means. They should be told that your child can remain absolutely well, your child will not be coughing at all, your child will not have any dyspnea, will not have breathlessness during exercise, will not require any emergency visits, will never be which should not be usually hospitalized, and the quality of life will be absolutely normal, and he can do whatever he wants or he or she wants to do. So these things should be emphasized to parents, that what are the goals of management of a child with asthma, and what do we mean by a well-controlled asthma. We should clearly tell them what is the role of medicines, which includes preventers, which includes relievers, the inhaler technique, the use of spacers, how to monitor ourselves, how to handle yourself when the asthma goes worse, when should you report back to us, and how to prevent the environmental exposure or control measures. So all these things should be a part of the asthma education, and these should be done at every visit. So I think the second error is to not provide proper asthma education. So that's very important. Now third would be to select an appropriate device. And the devices could be a meter dose inhaler, it could be, in addition, it could be spacers or holding chambers. Sometimes you might be using dry powdered inhalers and occasionally nebulizers. Now, once we are using inhalational therapy, we need to know that the particles which are formed would be of different sizes by different devices. And the particles which actually reach the bronchi or the conducting airways would be this graph, the dotted graph, and would be somewhere between 2 or 3 microgram to somewhere between 7, 8 micrograms. And particles which are larger would actually get deposited in the oropharynx. So that's very important to understand. So the adequate sized particles should be formed by the device which we are using. The other important concept which everyone should know is that once we take any form of inhaled medicine, a part of the medicine actually gets deposited in the lung, and a very small amount of this medicine actually reaches to the systemic circulation. But a significantly larger amount actually goes from the mouth, is swallowed, goes to the GI tract and actually reaches the systemic circulation. So the amount of drug which actually reaches to the systemic circulation is much more from the oropharyngeal deposition than from absorption from the respiratory tract. And that means that if you can reduce the oropharyngeal deposition in children, it would significantly reduce the adverse effects. The right device, the criteria would be the age, the use of controllers, in what episodes you want to use them, and the drug deposition which would happen. Now we'll start with the nebulizer. So we have merits and demerits. The merits are that you can use it for an acute severe asthma where inhalers might be difficult to use, and where you actually run it not with compressed air but with oxygen. You can use larger doses, you can mix drugs, and it can be used even for ventilated patients, but it has a lot of drawbacks, like it is not portable, it has a long delivery time, the initial cost is quite high, it needs a lot of maintenance and cross infections. So nebulizers are time consuming, they are impractical for preventers, and we would never recommend a preventer to be used with a nebulizer. We have to understand that nebulizers are very inefficient system, and the amount of medicine which reaches to the lung is less than 5%, and most trials would say somewhere like 1%. It gives a false sense of security to parents, and they would keep on nebulizing at home and not report to the doctor. And if you calculate the cost of nebulized drugs used as preventers is at least 20 times higher as compared to inhaled medicines. And the usual questions would be that can we combine two drugs? So we should not try combining steroids with other medicines because one is a solution and the other is a suspension. We can combine salbutamol with ipratropium. The usual fill volume should be like 3 to 5 ml. And the flow rate should be somewhere like 8 to 10 liters per minute if you're trying to use a oxygen source. Now, the advantages of a meter dose inhaler are it is portable, it is convenient, it is lightweight, it contains multiple doses, so usually either 120 or 200 doses. It can be stored easily, it does not leak, it is effective, and it provides a consistent dosing. So every time that amount of microgram is going to come out. But the problems with the inhaler are that using the inhaler is quite difficult in children. So it requires something known as a hand breath asynchrony, which means that you have to initiate or you have to actuate the inhaler, and at the same time the child has to breathe in with a slow inhalation, and then the child has to hold his breath for around 10 seconds. So usually hand breath asynchrony is something which is a very common problem. They can have excessive inspiratory velocity, so which means they take not a slow inspiration but a deep inspiration like this, and it does not work as well. And something known as a cold freon effect, which means that the particles of the plume which is released is at a very low temperature. It hits the posterior pharyngeal wall and it leads to a catch in the breath, and the child actually does not take a deep breath up to the total lung capacity. So the child starts in the breath but stops in between. So something like this, and it does not go to the complete breath. So the larger particles will deposit on the posterior pharyngeal wall, and as I said previously, the deposition on the oropharynx is important because the absorption leads to systemic side effects, and those changes are seen with changes in temperature. So this was a trial done from Dr. Cabra's group. No, sorry, this is a trial done outside, and it shows a lot of common errors which were there with pressure MDI use. So hand breath discoordination, too short breath hold, too fast inspiration, not shaking, and so on. So there are a big number of errors which can happen with use of an MDI. Right. Now, what is the solution? We have a very easy solution which should be done in all patients. So we use spacers with inhalers. And as shown here, if you add a spacer to your inhalers, then the amount of medicine which reaches to the lung is significantly higher. So if you're using only an inhaler, then the amount of medicine which goes in is something like 5 to 10%. If you add a spacer, then it becomes 15 to 20%. Now, why does that happen? It happens because one, the particles which are released into the spacer, they get a space to expand. So as the particles travel forward, the plume would expand, and as it expands, the propellant which is actually on the drug will evaporate and the particles become smaller in size, and as they become smaller in size, they become more respirable. So the particle size actually becomes more accurate for getting deposited in the lung or in the conducting airways or bronchi. The hand breath symphony which was required with the pressure MDI does not need to be there with the spacer, and hence the amount of medicine which goes to the lung increases significantly. And as you can also see that when a person is taking an inhaler, the amount of medicine which gets deposited in the oropharynx is significantly high. Now, if you add a spacer, then the amount of medicine which actually gets deposited on the oropharynx is significantly less, and hence the systemic absorption reduces significantly. So we have created this graphic, and I show this to parents and tell them, look, if you use a spacer, the maximum amount of medicine goes into the lungs and not get deposited in the oropharynx. And they do definitely understand that yes, using a spacer is really important for their children. Now, how do we use a spacer? So we have a single breath technique and we have a multiple breath technique, and I'll try and demonstrate both these techniques to you. We have to understand that nose is a filter, and because nose is a filter, mouth breathing is something which is recommended, because if the child is actually breathing through the nose, the maximum amount of medicine actually gets deposited in the nose and in the nasopharynx as compared to in the lungs. Now, the role of the mask is for a younger child who actually cannot hold on to the mouthpiece and cannot breathe through that. In those circumstances, you would like to add on a mask. But we have to realize that once you add a mask, there are 2-3 problems with it. One, the amount of nasal breathing which happens when the mask is attached is significantly higher, and hence the effect will not be as good. And secondly, it adds a dead space, and the amount of particles which get deposited on the mask is also significant. So we will try and remove the mask as soon as the child becomes around 3 years and the child can actually hold on to the mouthpiece and breathe. And there are also studies which show that if you have a mask which is loosely fitting, for example, look at this figure. So this mask is loosely fitting and most of the drug gets actually deposited here. If the mask is tightly fitting, then the amount of medicine which actually goes to the lung improves significantly, and it holds true for nebulizers as well. So the mask fit has to be really good. So I'll try and demonstrate the device to you. So Jyoti, can we, I'll stop sharing screen. Can you make me full screen here? I'll just demonstrate the devices.
Sure. Now you are full screen, sir.
Am I full screen? I think I'm still not full screen.
Sir, it is full screen now.
On my screen, you are showing as full screen.
Sir, we are able to see you as a full screen.
You see as full screen? Okay. Okay, so no, you'll not be able to see the slides. I'm trying to demonstrate the device. You can see me as full screen, right? Okay. So this is the pressure MDI, and it has a canister and it has an actuator, and the medicine is in this. I'll not try and demonstrate to you the way we take up an MDI without a spacer, because at no point of time we recommend using an MDI without a spacer. So that is totally out. We will try and demonstrate how we use an inhaler with a spacer, with and without a mask. So let's look at this spacer. So this has a mask, and let's imagine that you have an older child, 7-8 years of age. So we are obviously not going to use the mask. That's something which is extremely important to understand. We'll not use the mask. We'll use a spacer with a mouthpiece. So this is the mouthpiece. So this is the mouthpiece, and at this end you will actually put in your inhaler, and it has a valve, and if you can see, the valve can be seen. It is a fish mouth valve, and I can open from this end and also show you the valve like this. Right, so once the child would breathe in and breathe out, the valve would move in and out, and it provides a good seal when the child tries to breathe out into the spacer. Now, for older children, what we use is something known as a single breath technique. So what we would do is that we would actually shake the inhaler. Uh, so shake it, put it into the spacer, and the child is asked to breathe out first, right? So the child breathes out first, then it is put into the mouth. After that, the child or the parent would help them and actuate the inhaler into the spacer. The child then takes a deep breath through the mouth. So that's important, through the mouth. And then the child holds his breath for around 10 seconds. And it is done. So it is a single breath technique, so which means the child just takes in one breath, everything goes in a single breath, and the child has to hold his breath for 10 seconds. Right? So that is the best technique which can be used in any child who is older than 5-6 years of age, provided the child is able to do this technique in front of you properly. Right? So the most important thing is that you have to teach the child to do this. If a child cannot hold his breath, then I will not advise a child to go back on this technique at all. Now, for a younger child, so let's imagine the child is 4 years or 5 years of age. So again, you will use a spacer with a mask, a spacer and an inhaler, but still not the mask, because this child can actually hold on to the mouthpiece and breathe. But now we'll not use a single breath technique, rather we use a multiple breath technique. So what it means is that you shake this, put it like this, right? The child holds on to the mouthpiece, you actuate the inhaler, and the child is going to slowly breathe in and out in the spacer for around 6 to 10 breaths. So we have to remember they are not deep breaths, they are not fast breaths, it is tidal breathing. Why? Because if it is a deep breath, everything actually goes in and it comes out immediately. So it has to be around 6 to 10 tidal breaths, slow breaths. So easy breaths, but make sure that the child is actually breathing through the mouth and not through the nose. Then otherwise nothing is going to go in. Now, if you have a younger child who is less than around 3-4 years of age, then what you need to add on is a mask. So you put a mask on the spacer, right? Because this child cannot hold on to the mouthpiece quite well, right? And you ask the parents to put the mask on like this, actuate a puff, and ask the child to breathe in and out through this for around 20 to 30 seconds. So make sure it is a good seal. Make sure that the child is breathing through the mouth as far as possible. So these are the usual ways we would use inhalers and spacers at different ages. Right, so we'll go on to the presentation after this. So I'll show you in brief the usual errors which would happen. Right. Okay, so try and identify what errors are there. So one, this is an older child. This child should be without a mask. So that's one. Second, this child is not opening his mouth. So it is totally nasal breathing, and hence it is something which is not going to be very effective. So breathing through the nose is not a good option. Breathing through the nose is not a good option. And the mask should not be used. Okay. Okay. So what's wrong with this child? Now, if you look carefully again, this is a bit of an older child where I would say still a mask should not be used. And this child is making good effort to breathe, but it is all nasal breathing. So it's all nasal breathing. So the child is actually taking breaths through the nose. The child is trying to breathe. That's not a good way of using an inhaler and spacer. Okay, let's look at this. So again, older child, nasal breathing. This is the commonest thing which we would see, and that is something which should not be done. And look at the position of the neck. It has to be in a neutral position. The neck is hyperextended and hence it is not going to work. Okay. So again, the same problem, nasal breathing. So they are trying to do a single breath technique, breathing through the nose. The mother is taking a lot of effort in getting the maneuver done, but the problem is that we haven't taught the maneuver properly. So we are the people who should teach parents. Okay, let's see this child. Okay, so the problem is that this child is not holding on to the spacer properly. Okay, so this child is not holding on to the spacer properly and not breathing through the mouth. So actually nothing is going in. Now let's look at this child carefully. This is interesting. So what's wrong with this technique? So let's look at this again. This is interesting. So look at this child. So what this child does is that before this, the inhaler is actually actuated into the spacer, the child actually breathes in. So that's important. The first you have to actuate the inhaler and only then the child has to breathe in. Otherwise nothing goes in. Then that's also a common error which we see with older patients. So let's go on to dry powdered inhalers. They're also portable. They are breath actuated. They do not have propellants, and those inhalation can be checked. But it requires a high inspiratory flow, which sometimes can be difficult in children. It always has a large amount of pharyngeal deposition. That's important for kids. It may not be available with all formulations. It is for single use and it can induce a lot of coughs in future. Now, once we compare all these devices, this is a very nice graph which tells you about the deposition in the lungs, which is shown here, the oropharyngeal deposition, which is this part, and the amount of deposition which is there in the device, so which is the lined part. And if you look at an MDI alone or a DPI, then the amount of medicine which has got into the lungs is something like around 5 to 10%, but the amount of medicine which gets deposited in the oropharynx is significantly higher, and that is what leads to adverse effects. On the other hand, if you compare an MDI with a spacer, then the amount of medicine which is deposited in the lungs improves significantly, and the oropharyngeal deposition gets really low. And that's important. That reduces the adverse effects, and that is the real benefit of using a spacer with the inhaler. And even with the nebulizer, the amount of medicine is less. The oropharyngeal deposition may not be as high, and this is the deposition in the device. So, in a child who is less than 3 years of age, use an MDI with a spacer with a mask or a nebulizer with a face mask, but that's never a good option for preventers. In children who are between 3 and 6 years of age, use a spacer with a mouthpiece. Try and use without a mask if possible, but use a multiple breath technique, not a single breath technique or a breath hold technique. In children who are more than 6 years of age, try and use an MDI with a spacer and hold a single breath technique. So teach them to hold their breaths. Remember that you do not have very clear cutoffs. It depends on the child. The child should be able to perform the technique in front of you, and the parent should be confident enough to do that. Only then I would send the child on that technique home. Now let's come back to REMGEM. So we talk to parents about acute flare-up or exacerbations. That what would you do if you have increase in symptoms or flare-up, and do you have a written asthma action plan? And the answers were that, doc, we have a nebulizer at home, we have nebulization with salbutamol and budesonide for a few days and she becomes better. Isn't that correct? I was told you nebulize with a combination of these. And no, doc, we were never mentioned about an asthma action plan. So if you look at acute flare-ups and compare nebulizers with spacers, then MDI spacers is definitely a good option even during flare-ups, especially during mild to moderate asthma, not for severe asthma. And there's a Cochrane meta-analysis which says that the length of hospital stay is slightly shorter when you use inhalers and spacers, and the side effects are definitely less. So the amount of tachycardia and tremors which happen is definitely less. And there is no difference between homemade spacers or commercially available spacers or different types of spacers. You can use whatever you have with you. So in acute episodes, definitely you can use an MDI with spacer with and without a mask. Obviously not a DPI in exacerbations. In the hospital, the same can be used. Occasionally nebulizers for severe episodes, but remember at that time they have to be run with oxygen and not with air. Nebulized steroids are very commonly used in flare-ups, but remember that a lot of data comes up which says that they're not very useful during exacerbations. And if you want to use steroids, it has to be oral steroids. And these are two meta-analyses which have been published, which says that inhaled or nebulized steroids do not work during exacerbations, and that should not be done. So choosing an inappropriate device for age and drug and choosing multiple devices is another problem. So we'll come to written asthma action plans. So it is a set of written instructions which guide prevention and home management of symptoms and exacerbations. It can either be PEF or the peak expiratory flow based or symptom based. This is what we have devised for our clinic and hospital. So it has a green zone, a yellow zone, and a red zone. So the green zone is when they're doing well, what they need to continue, how much to continue, and when to take. Then you have a yellow zone when asthma is getting worse, what they need to do. So they have a quick relief medicine which they have. It needs to be added, in how much dose it needs to be added, and at what frequency they need to take it. It also tells that you might need to add an oral steroid, but usually we keep it reserved for us. And we also tell them that if you have an exacerbation, if you are using your blue puff, then kindly come back to us and see us and not sit at home. And there would be patients who might get into the red zone, and when we tell them that you have to take one dose of prednisolone, don't wait for that. Take 4 puffs at one time, repeat after 20 and 20 minutes, and come to the emergency or reach to the nearest emergency to your hospital. Don't wait for us. And these asthma action plans have really shown that they reduce hospital admissions, acute care visits. And it is important to understand that peak flow based asthma action plans are not very useful for children, and everywhere across the world, pediatric pulmonologists tend to use symptom based plan, and that is what we use as well. So not prescribing asthma action plan is another error, and using a PF based plan is another one. Now, we come back to RIMGIM and we ask the parents, would you please show me how do you take your inhalers? And let's see, we might be able to improve it, because the usual question would be, I can take it well. I have been taking this for a while and I can do it. So we usually say, yeah, I know you can do it well. I know you can do it well, but let's see, we might improve a step or that. Now, when she was doing that, you realize that the canister had finished. She did not exhale well. And remember that RIMGIM is an older child where we want a single breath technique without a mask. She did not exhale well. Now, when she activated the inhaler, she was not taking a deep breath to total lung capacity, and she did not hold well. These are important errors which will lead to a lot of problems, because the medicine actually doesn't go in. And also remember that you need to demonstrate how to use the selected device. It is not a very simple thing. And it involves 4 steps. So you choose the device, you check it, you show it to them, and you check how they are doing it. You don't assume that you have told them and they will do it at home. No, that never happens, and that's the basic error which happens there. So they need to show it to you that yes, they are doing it properly, and they have to show it to you at every visit. And we have had patients who have been taking inhalers for a year, 2 years, and they start to lose control, and you're really scratching your head that what's going wrong, and you go back to technique and realize that even after 1 to 2 years, they have changed their technique, they've gone to a wrong technique. And sometimes when you have a patient who is coming to you in a follow-up regularly, you sometimes tend to feel, yes, this child has been taking his inhalers and spacers quite well. And sometimes they don't carry it, and you are in a busy OPD and you don't check it, and that's when the problem arises. And you correct the steps, what they have done wrong, and you confirm it. So it is a tedious task in a busy OPD, but these things have to be done. These things have to be done. So you choose, you check, you correct, and then you confirm. So it's important all these steps are done in this order. So that's the error 4. Not following the 4 C's: choose, demonstrate, check, correct, and confirm. Now, selecting the appropriate drug and appropriate dose. So, this is the dose table for children less than 12 and more than 12. So, you choose what you want to give, budesonide or fluticasone or cyclosinide. Cyclosinide is now hardly available. So, what we have available in the Indian setup is either budesonide or fluticasone. So, fluticasone is again back. We can choose either of them. Anyone can go across to the ATM or the ABC guidelines or the GINA guidelines, the BTS guidelines, and print out the table and keep it on your desk. You also need to remember that the dose response curve for inhaled corticosteroids, because if you look at this graph, it shows the clinical effect, and if you look at this dotted graph, it shows the adverse effect. Now, from around 50 micrograms to 200 micrograms, the curve is very steep and there is a significant clinical effect as the drug is increased. So if you keep a budesonide at 100 microgram and take it to 200, then the amount of response increases significantly, right? Now, when you go from 200 to 400, then there is still some increment in the response, but not as much. But if you go beyond 400 or so, the response actually does not increase in most patients. There would be some patients where that happens, but for most patients that does not happen. On the contrary, if you're moving from 400 and above, the response does not improve. The clinical effect does not improve, but the adverse effects increase significantly. And that is what is shown in this graph, and it is important to remember. So try and be in the green zone, not in the orange or in the red zone, because the effect is not going to be much, but the side effects are going to be high. Now, once you have initiated your controller therapy, start at an appropriate step, and GINA 2020 has given a very beautiful table at what step you need to start the child on. Try and assess control in the domain of current impairment and risk, and then you assess, adjust, and review your treatment. So this is the GINA 2020 for children who are 6 to 11 years of age. All these steps are given in your GINA, and I'll not go into the details because that's not the agenda for today's webinar. But what we need to know is that you need to review the response, you need to assess, and you need to adjust. And that adjustment is important. You might have to up titrate your medicines, you might need to down titrate your medicines. But it is not just about medicines, it is about the rest of the things which we have talked about as well. And you have a table for under 5 children as well. So we should know what step of treatment we are doing. We should know what is the step ladder we are following and how to up and down titrate medicines. And once children are very well controlled for around 3 months, we would reduce steroids by 25% to 50%. If you're using combination of ICS and LABA, reduce the ICS first and continue LABA till you reach to the lowest dose of ICS and then remove LABA and then continue with low dose corticosteroids. And you can switch to once a day corticosteroids as well. So I think another error which we commonly see is that once the child is started on a amount of medicine, no one reduces it. No one reviews the response or adjusts treatment. So that is another thing which is an error which I would like to highlight. So your prescription should include a controller, so 200 micrograms of budesonide, 1 puff twice a day. It should also talk about a reliever, which is your salbutamol, 100 microgram, 2 puffs if needed. It should talk about a spacer. It should talk about device demonstration, that we have demonstrated the device and we feel that the parents are confident enough to do that. We should provide a written asthma action plan. We have shown you one. Loads are available on the internet. And we should ask the parents to maintain an asthma diary. So with that, we would end this talk. These are the services which we perform at our department at BLK Hospital, which includes bronchoscopy for all ages, foreign body extractions, lung functions including oscillometries, allergy services, and sleep services. So I would end here and